Now. So again, pre-hospital care of exertional heat stroke, cool first, transport second. We're going to talk about why that's important. So first, to introduce myself, I know that we have a lot of people joining from Connecticut. We have people from Massachusetts, of course, Rhode Island. And again, I thank you all for joining on. My name is John Jardine. I'm one of the attendings at Our Lady of Fatima Hospital in North Providence, Rhode Island. My beginnings were in EMS, so I get it. I still understand what's happening in the field. And, when we talk about some of these changes or something, how EMS can deal with pre-hospital care of heat stroke, I recognize the challenges, et cetera. I've been an ER doc for more than 20 years. I became the medical director of the Falmouth road race back in 2002. And you can see we treated a bunch of exertional heat stroke there. And that's pretty much where my experience comes from. I'm now a member of the Sports Medicine Committee for Massachusetts, and I'm the Chief Medical Officer for the Corey Stringer Institute at UConn. Just a little bit about that. This is Corey Stringer. For those of you who don't know, he played for the Minnesota Vikings on August 1st, 2001, so just about 20 years now. He succumbed to heat stroke. He died from heat stroke. He's the only NFL player to die, while playing football. This happened during training. It was a training camp in Minnesota, and it was, believe it or not, in Minnesota, it was so hot in Minnesota during that time that farmers were advised to keep their livestock out of the sun because it was so hot. Corey collapsed on day one, came back to practice on the second day, collapsed again, and unfortunately succumbed to heat stroke. His widow got the help of a guy named Doug Casa at the University of Connecticut, who was an expert on heat illness at the time, helped with a trial with the NFL, and the NFL gave a settlement to her. And then she turned it over to Doug at the University of Connecticut to form the Corey Stringer Institute. So in honor of Corey Stringer, this is the Corey Stringer Institute at the University of Connecticut. And what we do there is, research not only in heat stroke, but also concussion and other things that can, certainly hamper athletics or active folks. So again, we'll talk a little bit about that as we go along too. My experience, again, primarily is as being the medical director of the Falmouth road race for the past, 20 years or so. We see a lot of heat stroke there. We'll talk a lot about Falmouth. I've also, been in the medical tents at the Boston Marathon 2012. The Boston Marathon typically is held in April. This year it's going to be in October, but typically it's held in April. 2012, it was 95 degrees in April. And you might remember 2018 was about 30 degrees. It was raining and miserable. So, all extremes of temperature there at the Boston Marathon. Run to Remember is another run in Boston that I direct as well. That's Memorial Day weekend. We see a fair amount of heat stroke there. Marine Corps Marathon is in Washington, D.C. We've taken our services there. And again, as the Chief Medical Officer for KSI. And that's really opened a lot of doors. And, I've been called as an expert witness now in legal cases, both, people who have succumbed to heat stroke and or have morbidity afterwards. And that's been interesting to see from that perspective, and I hope that after this lecture, you'll agree that really no one should die from heat stroke. It's relatively simple to treat, and really none of these kids, and especially these young athletes, should be dying from heat stroke. I was invited to Washington, D.C. to write with to meet with the Armed Services to write the protocols for the Marine Corps Marathon, and the Armed Services and the International Institute of Race Medicine has adopted those protocols. So again, on the policy side, bringing the clinical to the policy side now, writing protocols. I reviewed the plan for the International Track and Field Championship in 2019. If anybody follows sports, that was in Qatar in the Middle East. And again, if anybody watched that or followed that, you may remember that the women's marathon started at midnight because it's so hot over there. And even at midnight, it was 90 degrees and 70% humidity. So we had to come up with a plan for how to take care of the people in the heat there. I also reviewed the Olympic protocols that are in place right now in Tokyo. for heat illness as well. We have some colleagues there. And then very recently at Corey Stringer, we brought the U.S. women's national soccer team over for a week to get them heat acclimatized to go over to Tokyo. We weren't allowed to take pictures, but Megan Rapinoe tweeted this picture out, so I can show this picture. So again, we brought them over to our heat lab in Yukon and got them ready to go to Tokyo. So that was, again, lots of opportunity in this field. So the learning objectives tonight, I'm gonna talk about temperature regulation and heat illnesses, a little bit of pathophysiology, a little bit of the boring stuff first. We'll define exertional heat illness, including, of course, exertional heat stroke, and then discuss the treatment of heat stroke, obviously, which is the main gist of this lecture. And then, of course, the role of EMS in the treatment of heat illness, and where do you guys fit in? Where does EMS fit in, and how does it all come together? And then present a new paradigm, perhaps, for the pre-hospital care of exertional heat stroke, maybe something you haven't thought of or even considered. So, again, having a background in EMS, I understand, the EMS conundrum sometimes, right? When you have a patient, do you scoop and run or do you stay and play? Is it something that needs to go right away, or is it, do you have some time to, intervene a little bit on scene or on the way to the hospital? So we do know that there are some diagnoses that we want to rush to the hospital, right? So certainly STEMI, ST elevation, MI, we want to get to a cath lab just as soon as we can, because we're preserving heart muscle, and, and the door to balloon time is important to get somebody there, right away. So again, these are a diagnosis that needs to go quickly to the hospital, and then now stroke too, right? So stroke is another of these diagnoses that we need to identify right away, get to a stroke center, and, get treated right away. So I would suggest to you that heat stroke is one of these timely diagnoses. You can see this, this is a study that was done back in the 70s, and it was done with rats. And what they did was they heated up rats and they, measured their survivability. And you can see with both passive and exertional heat stroke, after about 30 minutes, the survivability falls off dramatically. So, we essentially have 30 minutes or so to, get these people treated and get this turned around. So again, this is a diagnosis, and this is what I'm going to kind of focus on. This is something that needs to be done quickly, treated quickly, for people to survive. So I'm going to present two scenarios of exertional heat stroke. One in which you're prepared for it. In other words, like you have a race coming up or you have an event coming up where you're prepared, that there may be exertional heat stroke happening. And then, of course, when it happens in the emergent setting and you're maybe not so prepared for it or not ready for it. So I just want to take you outside for a little bit, and towards the end of August, if you look into the southwestern sky, you'll see Sirius, the star Sirius, which is the brightest star in the sky at that time, and that is in the that's called the Dog Star because it's in the Dog constellation. Again, this is late August, and this is where the term "the dog days of summer" comes from. When the appearance of that star in the sky in late August and late summer, the term "the dog days of summer" was coined way back, 3000 BC. So this is not something new, right? This is not something that we just all of a sudden know about. I mean, this has been recognized, again, from as far back as 3000 BC. And if you look at the saying there, the Sirius brought fever in men and madness in dogs, and was introduced into medical literature as psoriasis. And that term stayed until well into the 20th century. So again, this was identified that, the hot times of summer is going to cause some heat illness. So fast forward to 1973, that's when the Falmouth road race was first run. It's a 7-mile race. And why is it 7 miles? Well, it was run from one bar to another bar, and the distance between those bars is 7 miles. So it is kind of a weird distance when you think about races, but that's how that's how it was formed. And it's run now the third Sunday in August. So again, it's the hot part of the summer. It's the dog days of summer, and that's why we see lots of exertional heat illness. We have they register more than 12,800 runners. They register somewhere in the neighborhood of 13,000 runners. And of course, the spectators are in the hundreds of thousands. Falmouth in the summertime is crowded anyway. So, there are lots of people around during this race. The medical care provided by our team, it's all volunteers. So it's all medical volunteers of all sorts, EMTs, nurses, athletic trainers, physicians, even just sort of people who want to volunteer and just do clerical stuff. I mean, we accept all comers. So again, it's all provided by volunteers. Because this is, what you're going to see. This is the starting line of the Falmouth Road Race. This is, again, 13,000 people lined up to run the 7 miles to the finish. So again, lots of people to worry about there. So again, if you're prepared for something like this, you're prepared for a race or an event outside, you organize your medical team. We've done some, a paper on how to organize a medical team. And, obviously you have to work with your local EMS, you have to work with the local hospital, the police, et cetera. Kind of makes sense, right? So you get your team in place and you get everything in place ready for your event. And then you form your team, right? You get volunteers paid however you want to staff your team. But again, we're all volunteers. We have in the neighborhood of 200 volunteers for the Falmouth race. This is a picture from a few years ago. So what you have to do too is develop some sort of training program, right? Because not everybody knows about heat illness, or not everybody may know what's going to happen during an outside event like this. So you need to develop a training program and you need to roll it out to the people. And then you need to position yourself where you can do the most good. We have 5 medical tents throughout the course. And of course, the biggest one here is at the finish line. This is the big tent at the finish line, where most of the people are going to, succumb to any heat illness is at the end of the race. So again, you position yourself where you can do the most good. And then you think about we mentioned the 6 H's, the 6 things that can cause an athlete or an active person in the heat to collapse. And certainly in late August for the race, we think about heat, heart-related issues, hyponatremia, which is low sodium, which we don't see a lot of in this short race. You see that more in, say, marathons or longer events. Hypoglycemia, of course, low blood sugar can happen at any time. Hemoglobin, or people who have sickle cell disease or sickle trait, may collapse because of the heat or because of the event. And then, of course, head injury, which, hopefully we don't run into head injuries with a running road race. And of course, we are EMS folks, right? So we add that 7th H, the holy crap, right? We're ready for kind of everything. The sad reality of, Boston 2013, shows that you need to kind of be ready for everything. So temperature regulation. So just briefly, a little stuff about physiology. Body temperature is dependent on the balance between the heat production from metabolism and the heat loss, or sometimes the gain to the environment. So it's a balance issue between what you're producing and what you're getting rid of. And of course, any environmental heat stress increases the need for heat removal. You need to get rid of the heat that you're forming. And the problem is this, is that heat production during intense exercise is 15 to 20 times greater than at rest, and can raise your core body temperature almost 2 degrees every 5 minutes if you don't remove the heat from the body. So you can see what's going to happen is that, people are going to overheat. So how do we respond to this? How does the body respond to this? Well, obviously, we've all been outside in the heat. You know that you increase your sweat production. You start to sweat. The sweat evaporates from the skin, cools the skin and the blood underneath. Blood is diverted away from the inner organs out to the peripheral vessels so that the blood can be cooled by this evaporation process. And you get blood flow to the skin obviously increases. So this is how we respond normally. The problem is that when the heat produced by muscles during these activities outpaces your ability to transfer heat to the surroundings or to lose heat, the core temperature rises to levels that actually start to disrupt organ function. And this is where you run into problems, is that if you can't get rid of the heat, you can't compensate any longer. And the heat injury causes an acute phase response similar to sepsis. So those of us who are in the medical field, that sepsis is sort of causes end organ damage, and particularly in this case, it's to the central nervous system. So what are some of the things that we can see in, what are some of the heat illnesses? Typically we see heat cramps, and these have been sort of misidentified and relabeled as exercise-associated muscle cramps. We don't believe that it's actually caused by the heat, but certainly occurs more often in the heat. So it occurs in individuals who are, of course, sweating and then sometimes replacing their fluid loss with hypotonic fluid. So you're losing electrolytes, but you're replacing, say, your sweat with just water. And it involves painful involuntary spasms of the large muscles of the limbs or even in the abdominal wall. So the treatment is to, of course, rest in a cool environment, gentle static stretching of the muscles. We have, at the race, in the finish line tent, we have physical therapists, we have massage therapists, we have chiropractors who work on, people who have these exertional cramps for stretching, etc. Fluid and salt replacement, either orally or IV. Usually people can do it orally. Again, if you're replacing, some of the electrolytes that you lost, it helps with the cramps. People who have protracted cramping, this is when you start to think about things like hyponatremia or a low serum sodium level. Again, we don't see it a lot or hardly ever at all in Falmouth because it's a short distance, but certainly in marathons or longer events is when you start worrying about low sodium levels. Heat exhaustion is certainly the most common heat illness that we're going to see. It's simply defined as the inability to continue exercise in the heat. And what happens is you have an inadequate cardiovascular compensation because you're fluid depleted. So you can't compensate for the heat loss because you don't have enough fluids. The good thing is that if you give fluids, the signs and symptoms go away. It's sort of easily treatable, if you will. The symptoms of heat exhaustion are really kind of nonspecific and varied all over the place, right? People could be dizzy, weak, lightheaded, sometimes nauseous, vomiting, headaches. They just ache all over. So again, these are symptoms that are pretty nonspecific, but certainly show up with heat exhaustion. The important things to remember, though, is that the mental status remains normal. So the people are cognizant, their mental status is normal, CNS function is normal, and of course they're sweating because they've been active in the heat. Now, heat stroke or exertional heat stroke is a life-threatening emergency. And again, that's what we're going to focus our talk on. And classically defined, it's a temperature greater than 104.5 with central nervous system dysfunction. Now, if you read different textbooks, that temperature sometimes floats around. It could be 104, 104.5, you may even see 105, but certainly a high body temperature, hyperthermia with CNS dysfunction. So you have to be altered in some way. These people look terribly sick. Their skin is ashen. They lose what we call hind limb function. And these are people that collapse because they can't walk alone. That's primarily what happens is you have the heat first affects the cerebellum, and that affects patients' balance and ability to walk. So that's why they typically will collapse. This is pathophysiology, and again, this is a little more than we're going to get into depth, but certainly you can see what happens is that as the temperature goes up, you have an inflammatory response. Again, it's similar to sepsis that ultimately ends up with multi-organ failure and unfortunately death if not treated. So you can see that there's a sort of a pathway, again, similar to sepsis, leading to either end organ function or death. And it affects all systems of the body. Again, neurologically, it is typically first. And again, as I mentioned, it typically affects the cerebellum first. So your balance, your ability to walk is certainly altered. But you can see that it affects all systems, kind of all at once. Again, similar to sepsis, it's multi-organ failure and sort of a cascade that leads ultimately to death. So this guy in the bottom here, this is Hunter Knighton. He is he played for the University of Miami. He suffered a heat stroke and was in a coma for a long time, but he obviously survived. And his quote here is, a lot of people think of typical heat stroke as the older person in the house or a baby locked in a car. But there is a difference between that and exertional heat stroke. So, I remember learning certainly in medical school and probably as an EMT as well, you learn about classic heat stroke, right? And these are the folks, like he said, the little old lady who's locked in her apartment with no air conditioning, or maybe a kid that's locked in a car. And they have what we call classic heat stroke. Their temperature rises but they haven't been exerting themselves. So they actually may present with hot, dry skin. And that's the problem with when we talk about exertional heat stroke is that people remember classic heat stroke and they're looking for people with hot, dry skin. And that isn't the case with exertional heat stroke because, these people have been active in the heat, and there's going to be profuse sweating. The other thing about classic heat stroke is that these patients tend to have more severe underlying comorbidities. So again, the little old lady locked in her apartment with comorbidities is going to result in a significantly higher mortality rate. So people are going to die from classic heat stroke, and you've probably heard about cases, certainly when there's heat waves, again, if there's people, in their apartments or sometimes homeless people who have no, recourse to get out of the heat. I remember there was a heat wave back in 1995 in Chicago, and, there were, I think, literally thousands of people that died from the heat, classic heat stroke. Now, again, contrast that with exertional heat stroke. This is, exertional obviously defines people who have been active in the heat and they are sweating. And it could be, we're talking about athletes, runners, certainly firefighters in in an intense situation, and of course the soldiers, the military folks who are exerting themselves. So again, we're talking about active populations. My experience is with athletics and running, but certainly it occurs. Preseason and football practice in late August is sometimes deadly. And again, there are cases every year of kids who are dying from heat stroke. We're getting more into the at KSI. We're getting more into the occupational setting now because there are again people succumbing to heat stroke when they're working in the heat, and of course our military folks who are stressed by the heat in their activities as well. So again, these are just some occupational things. Firefighter dies of heat stroke, and migrant workers who are outside, and construction people. Again, people who are working outside or active outside, are active folks in the heat and are at risk for exertional heat stroke as well. So now when we talk about, recognizing it, the question always comes up, do we need an accurate temperature? And we do, because we want to determine if it is or isn't exertional heat stroke, right? We know that there's a temperature definition for exertional heat stroke. And, and we want to know, is somebody, has somebody collapsed because of exertional heat stroke, or is it another cause? Is it just heat exhaustion, or is it perhaps a head injury, or is it, again, low body sodium, no hyponatremia, certainly again in longer events? Is it just simply hypoglycemia, a blood glucose issue, or is it something else? So it's important to know an accurate temperature. If you look at this study that was done, again, across the top, you see 5 reasons for people to collapse. Again, we talked about heat and sickling and hyponatremia and heart. And you see that the only one that has an elevated body temperature is exertional heat stroke. So when you're thinking about your differential diagnosis, you need a temperature because you need to know if it is exertional heat stroke or not. And again, exertional heat stroke can be life-threatening. So the other thing is it's going to help us determine when we're going to stop cooling somebody. We're going to, obviously, we're going to talk about cooling people. And we also want to know if an exertional heat stroke has occurred, because that's going to influence how we get people back into sports or back into the military, back on duty, back whatever the, back to play, so to speak. So, we need to know if it was an exertional heat stroke. So we have lots of options for assessing body temperature: axillary, in the armpit; oral, tympanic; temporal, the forehead stickers; ingestible thermistors. We've used those at the race for research; esophageal probes; and of course, rectal body temperatures. So when we talk about body temperature assessment, we need to know, we need a valid way of doing it, and we need something that's obviously logistically feasible, something that we can actually do in the field or do at one of these events. So an example of valid body temperatures are esophageal probes, measuring the temperature in the bladder, measuring the temperature in the pulmonary artery, or measuring the temperature in the GI system. You can see that these are very valid ways of getting a temperature, but certainly not, feasible for us in the field or sometimes even in the ER, right? So what is more feasible? Well, certainly oral temperatures, oral, meaning, like a tympanic, temporal, and then axillary are feasible. But what we need is something that's both valid and feasible, and that gives us a rectal temperature. So rectal temperature is the preferred method, is the recommended method to have both a valid and feasible way of assessing body temperature. And if you compare rectal to axillary, again, if you're taking an axillary temperature, you can see the difference here can be as much as 5 or 6 degrees. So certainly not, an axillary temperature is certainly not accurate to assess a body temperature, based on these findings in this study. Rectal versus oral, again, you can be off by a couple of degrees, and certainly not a good way of measuring body temperature when you need an exact measurement, a valid measurement. So oral, not so good. Tympanic, again, you can be off by 4 or 5 degrees. Certainly not going to be what we need for accurate body temperature measurement. And then I apologize, you can see infrared is incorrectly spelled there, but this is a study we did at Falmouth in 2019, the last running of the race. What we did was everyone that got a rectal temperature and was diagnosed with heat stroke, we also took a tympanic or oral temperature, AURAL, oral temperature. And you can see that all but 1 or 2 of the cases, if you're measuring with tympanic, would have been missed. So, it did identify 2 cases out of like 30 or so, but you can see that if you're relying on a tympanic temperature, you're going to miss exertional heat stroke. So again, this sort of fortifies the idea that a rectal temperature is the only accurate way of getting a core body temperature. And then rectal versus temporal, forget it. Temporal is just, I think it's like a random number generator. It's so far off that it is no way near accurate for core body temperatures. You can see the difference in temperature there. Can, again, anywhere between 5 and 6 degrees. So not a good method. The problem is getting people to do rectal temperatures, right? And we understand this. We understand this as a problem, and for some reason it's not, quote, socially acceptable, end quote. So again, we realize that problem, we realize that stumbling block, but again, rectal temperature is the only, both valid and feasible way of getting an accurate core body temperature. Again, let's go back to history. This is not new. So 1885, this was a trade magazine that described the treatment of what they called sunstroke, which is probably, heat stroke or such. The treatment, which must be instituted promptly, can be summed up in 3 words: reduce the temperature. So again, back in the 1800s, they knew they had to reduce the temperature. And they even had a protocol. They said that, he should therefore be at once removed to a shady place in fresh air, head slightly elevated, whole body, especially his head and chest, kept deluged with ice water. Again, this is the 1800s when they're talking about how to treat heat illness. So since there's been lots of research, right? And we're now an evidence-based practice. We want to know what's the evidence, where's the evidence, and what's the best way of doing it. Lots of stuff has been done over the years, certainly since the 1800s. But what we rely most on is this paper that was done in 2000 or published in 2007, Cold Water Immersion as the Gold Standard for Exertional Heat Stroke. And it was done by Doug Cossa and others. I mentioned Doug as the heat stroke expert who's involved with Corey Stringer. And again, the sort of the caveat here is the key to maximize the chances of surviving exertional heat stroke is rapidly decreasing the elevated core body temperature. Again, same thing they said in the 1800s, you have to bring the temperature down. And what they did in this study is they compared various methods of cooling, and you can see way over here, ice packs in the groin and stuff, all the way up to cold water immersion, ice water immersion. What I found interesting is there's one military one here, the helicopter downdraft. They actually use the spinning blades of the spinning rotor of the helicopter to cool people. And, that's somewhat effective because it's better than putting ice packs in the groin. But anyway, what the study showed clearly is that ice water immersion is the clear, gold standard for cooling elevated core body temperature. The cooling rate is far superior to any of the others. So because of that, the American College of Sports Medicine, our folks in the military, the IAAF, National Athletic Trainers Association, they all advocate the use of either ice water or cold water immersion for the treatment of heat stroke. So this is one of our tubs in Falmouth. This is what, one of the sort of the stations would look like, and really, I have no financial ties to Rubbermaid, but this is a Rubbermaid tub. This is a stock tub that, it's hard plastic, and it's filled with ice and water, and that's essentially it. This is the finish line tent at Falmouth. You can see that, I'll show you a study in a little bit, but we do see lots of heat stroke, so we have lots of tubs ready. And again, when you're prepared, you have an event, you prepare for it. You can prepare with lots of tubs. So again, lessons from the road, both from the Falmouth road races, I mentioned Boston, Run to Remember, Marine Corps. Certainly, this is the Boston Marathon. If anybody has been involved with the medical team at the Boston Marathon, the morning of the race, just before people get to the medical tents, they have a medical conference, and you can see here that this is Dr. Hemencourt. And he's showing the same slide, right? He's showing the slide from the cold water immersion being the gold standard. And again, they use cold water immersion at the Boston Marathon. This slide here. This is actually a picture from Falmouth, believe it or not. So they use the data that we got from Falmouth, for evidence-based at the Boston Marathon. And this is the medical tent. This is a 10A at the finish line of the marathon. And you can see that they have a heat deck there with cooling tubs ready. Again, the race is typically in April, but you never know. Again, 2012 was 95 degrees that day. This is the Run to Remember in Boston. This is in May. This is Memorial Day weekend. The finish here is kind of unique. They finish inside the seaport area, so the finish is inside, but again, we use cold water immersion there for heat stroke. This is the Marine Corps Marathon. Again, cold water immersion. They do it a little bit differently. They kind of hover the patient above the ice water and then kind of, douse them with it. But again, the cooling rates are similar. So again, this is used at the Marine Corps Marathon. This is in October in Washington, D.C. And then this is around the world. This is the top picture is the New York City Marathon. I have not volunteered there, but I have obviously some friends that do. The lower picture is Japan. For the Olympics, for the Tokyo Olympics, 2020 Olympics, which obviously are happening just in a few weeks. This will be the first time ever that they will use cold water immersion. There have been no physicians or athletic trainers in Japan that have ever used cold water immersion. So again, we did some reviewing with them, and for the first time ever, they'll be using cold water immersion for what are supposed to be the hottest Olympics ever on record. To the right there, you see the Netherlands. We had the medical director from the Netherlands marathon come and join us in the Falmouth tent in 2019. And then she brought the science back with her to the Netherlands, and they now used it for their marathon in the Netherlands and use cold water immersion there for the first time as well. Again, I don't have any financial responsibilities with either Rubbermaid or the Tractor Supply Company, but this is where where do I get one of these tubs? And this is where, right? So this is Tractor Supply. You can see this is a 100-gallon tub for $69. So again, $69 and some ice and water, and you can save somebody's life. So let's talk about some misconceptions about the tub. And the old timers in emergency medicine or in EMS will tell you that you can't dunk somebody in ice water. It's unsafe. It's you're going to stop their heart and stuff like that. The other thing is that people will say, well, if you put somebody in cold water, there's going to be peripheral vasoconstriction, and that actually stores heat. So you're going to make somebody actually get hotter when they're in a tub, and that is untrue. So there's something called the Curry response that, you can see the graph on the left here. Now, if you took one of us who have a normal body temperature and dunked us in one of these ice water tubs, yes, we're going to shiver, we're going to vasoconstrict, and our temperature may actually go up a little bit. But you can see there it's, barely half a degree. And then we're going to start to get cold, and we're going to start to, our temperature is going to go down. So this is a normal response. Again, this is vasoconstriction when it happens, again, for normal thermic people. When you're hyperthermic, when you're up around, we see people 108, 109. The highest I've seen is 111. When people come in with those kind of body temperatures, it is all cooling. There is no vasoconstriction. There is no little bump in temperature. It's all cooling. So there is no concern for vasoconstriction, storing heat, et cetera, when you put somebody who's hyperthermic in cold water immersion. The other thing is, again, people say, well, they're going to start shivering, and shivering is going to increase their body temperature. Again, when you're 108 or 109 degrees, I can tell you that when you go into that ice water tub, that you actually start to melt the ice. The ice starts to melt. That's how hot these people are. So there is no shivering in the, initially in the cooling process. Cardiovascular shock, again, people say, well, if you dunk somebody in ice water, their heart's going to stop, they're going to go into shock. Again, my experience with more than 400 heat strokes is I've never seen anything like that happen. And I don't know that there's any science to say that it would. Again, if you throw one of us into, cold water, it may or may not cause some problems, but certainly not people who are hyperthermic. The other worry is that if you put somebody in a tub of ice water, you can't administer other care. And I'll show you how that's not true. We use, 50-gallon tubs at the Falmouth road race. The tubs do come in all sizes. They, 50-gallon, 100-gallon, 150-gallon. And I can show you that, the reason that we use the 50s. And then there's something called after drop. And we do see after drop occasionally. When you cool somebody, their body continues to cool. And sometimes even if when they come out of the tub, they continue to cool. We think what happens is that the hypothalamus in the brain is sort of your thermostat, so to speak. So it takes a while for the thermostat to reset. And sometimes when you start cooling, you keep cooling. And some people actually end up a little bit cool, as far down as, say, 95 degrees or something like that. But certainly they're not going to die from being a little bit cooler than they should be, but would die from heat stroke. So this is a picture from the Run to Remember. This is a mesh stretcher. We use this to, we have these on the ground when patients come in, or we use them to pick up patients. And what we do then is just dunk them right into the ice water with it. So you don't have to be trying to, pick up a slippery, sweaty person. You put them on these mesh stretchers and you dunk that right into the tub. So again, that's convenient for moving people in and out. And this is what somebody looks like in a 50-gallon tub. And again, you have great access to people. You don't have to worry that you're going to lose them in the tub. They're not going to go under the water. You have access to their arms and legs if you need to get vital signs, et cetera. We typically don't routinely start IVs because people don't need it. Again, it's a short race. Most people are well hydrated or can hydrate after cooling. But if you need to start an IV, obviously you can see that you can get to the patient. The other thing to remember is this is going to be a team event, right? Especially if you're, preparing for something like this, you're going to have lots of hands on board. You're going to have lots of help. And even if you, came upon this emergently, or you're going to take care of somebody emergently, certainly this is not a one-person operation. So this is there's a team approach here. So you don't have to worry about, again, losing somebody in a tub or them going under or something like that. This is a picture of a patient who actually was unconscious and unresponsive when he crossed the finish line. He fell to his knees, and he had a body temperature of 109 when he came into the medical tent. He did have to be assisted. You can see there's a person at his head assisting to keep his head out of the water so that he doesn't go under. But again, this is a all hands on kind of team event. This guy again came in at 109. He was cooled. He got up and had some snacks and some drinks, and he went home with his family. So again, this is a sort of an easy fix, just some ice and water. So what happens in Falmouth, what's our actual protocol is that, patients who are brought into the medical tent are triaged at the tent. And of course, that's with a rectal temperature. So there is no, again, I just want to stress, there is no other way to get a temperature other than a rectal temperature. It has to be an accurate body temperature measurement. So we do get rectal temperatures. Our cutoff at Falmouth is 104. We use a definition of 104 plus the mental status changes. So again, somebody who may be unconscious, maybe comatose, maybe combative, maybe, just kind of goofy, but certainly there's an altered mental status. They're then moved to one of those treatment areas and they're immersed in the tubs that are filled with ice water. This is what somebody looks like in the tub. Again, this is a 50-gallon tub, so we have good access to the patient. And then you can cover them with towels, et cetera, and kind of just start to cool them. Various massages applied. Again, when you put somebody in an ice tub who's 108 or 109, the ice actually starts to melt. The thin layer of water next to the body actually starts to heat up. So you have to keep the water circulating. You have to keep the water flowing over the patient, and you have to sort of, massage the water over the whole body surface, because you want to cool as much body surface area as you can. You probably have seen or may see, with football players or, in sporting events, they do have much bigger tubs, right? Because they want to cover as much body surface area as possible. Again, we want to have good access to patients and not have to worry about somebody going underwater. Rectal temperatures are taken every 5 minutes or continuously monitored. We essentially use a thermistor at this point, much like we would in the hospital. You can see here, this is a patient with a 105. It's a rectal thermistor. It's about the thickness of like a phone charging cord. And it's inserted rectally, and then it gives you continuous temperature monitoring, and that stays in for the duration of, while the patient's in the tub and when they come out of the tub. Most patients don't even know it's there, and certainly don't remember that it was there. We actually, quite funny, actually, we had somebody who actually tried to walk away with it in, and we had to remind them that we had to take it out before they left. So again, most people don't even know it's there. And it's a continuous monitoring of temperature, so you can see what's actually happening while you're cooling somebody. The other thing to remember, if you do get to do this, or you do start to do this, these people have been active in the heat, right? So their initial temperature, even when you put them in the tub, their temperature may still be climbing. So it's not unusual to see a temperature climb for a little bit before it actually starts to come down. So again, not to worry about that. And then patients are removed from the tub when their temperature goes down to 102, or they've spent about 20 minutes in the tub. So again, we're continuously monitoring temperatures. When they get down to 102, we pull them out of the tub. Again, that's to avoid that after drop that I talked about, and avoid people from getting too cold. So we observe people for about another 20 to 60 minutes. Again, we keep the thermistor in for as long as they're able to tolerate it, and we can watch their temperature. Occasionally, people go back up, they have to go back in the tub, but that's a rarity. Anyway, so when patients are normal thermic, they have normal vital signs, they're cognitively well, they're taking oral fluids, we are comfortable, because we've done this for such a long time. We are comfortable discharging them from the tent as long as they have, a family member or friend to come and pick them up. Occasionally, we do have to send people to the ER. We have seen, of course, broken bones. We've seen, people who do need IVs because of dehydrated. We have seen seizures. So occasionally, we do have to send people to the ER. But for the most part, people are going to go home from the tent. And this is what we've seen through the years. Again, since 2002, when I've took over as medical director, and you can see there's been some ups and downs. 2003 was still our record year. It was nearly, I think it was like in the 90s, 90 degrees with 100% humidity that day. So you can imagine that it was a pretty hot day. And this is the percentage of people that go to the ER, and it's almost 90% of our people are going to go home from the tent. Again, it's rare that we have to send people in to the ER. So we're essentially protecting the ER, doing this on site, and certainly it helps people get back to normal lives. So again, we're comfortable with our protocol. We're comfortable with the people that are there. If you have worked at another race or worked at other events, such as the Boston Marathon or other events, some opt to send everybody to the hospital. So, you know, in a place like Boston, you can do that. You can pick and choose hospitals. But a place like Falmouth, where there's only one hospital, you can't really inundate the ER. So we're comfortable sending people home. So, you know, with all this data that we've accumulated at Falmouth, we said, hey, we should, you know, really publish this stuff. So back in 2014, we looked at the effectiveness of cold water immersion for treatment at the Falmouth road race. We were able to get, you know, my data from 2003 on, and then some data prior to that we got from the previous medical directors who, you know, held on to some files, et cetera. So we were able to compile all of these numbers, and we see that, you know, we see about 2 heat strokes per 1,000 finishers. So again, there's roughly 13,000 people registered. So we're going to see about 20 heat strokes a year at Falmouth, and that's what we've, you know, the mean has been over the years. We looked at, you know, male versus female, you know, real hot temperatures versus not so hot temperatures. We looked at all age groups, and really there was no difference in any of the cooling rates between males, females, real hot temperatures, age groups. It's all about the same. So again, when you look at the time that I've accumulated data over the past 20 years, we've had 388 exertional heat strokes, plus an additional 91 that we were able to accumulate prior to that. The point of this is that it's 100% survivable, right? We have shown that with this large data set that if you treat exertional heat stroke with cold water immersion, especially, you know, in a timely fashion within 30 minutes, that it is 100% survivable. And that's the whole point of this. So back to the EMS conundrum, you know, again, the scoop and run versus stay and play, you know, should we deliver these people quickly to the ER? You know, I said it's a timely diagnosis, so should we go right to the ER? So the question then comes up, you know, can we do this in the ER? Can we cool somebody in the ER? Again, I work in a community hospital. This is a, you know, a typical bed in a community hospital. This is kind of what it looks like. I know most of you folks have probably seen it. So, you know, can we do this here, right? So, of course, if you're in the Falmouth ER on the day of the race, there are 2 tubs waiting there in the decon room. Again, we're prepared for this event, but otherwise, I mean, not many people have the luxury of having a decon room like this with a drain and or having a tub, you know, ready to go with ice water. So, you know, how do we prepare for this kind of stuff, or how do we do it in the ER? The other thing is temperature measurement, and this is a you know, this is, as you recognize, is probably a temporal thermometer that is used in our ER. And I know there are some folks from my ER on this lecture, but I will say that the reason that this thing is cabled to this little cart is because otherwise I'd throw it in the trash, because I don't think that it's, you know, certainly not an accurate measure of temperature. And certainly not a good core measurement for core body temperature. It's great for people who have sprained their ankle. It's great for people who are, you know, not there because of a temperature issue, but certainly not what we need for core temperature measurement. And again, I remind you of the study that shows just how far off it is. Temporal, you know, obviously cannot be used as a measure for core body temperature. So we were all taught, and again, you saw that study, you know, we were all taught when somebody has exertional hyperthermia, or they're hyperthermic, you know, grab the ice packs and start putting them in the groin and the under the armpits and around the neck, right? Start packing ice packs around the major arteries. So this was a review done in 2009, published in 2009, and this again looked at various cooling modalities and you know, whether the cooling rate was acceptable or certainly ideal or just not acceptable at all. So when we look at, you know, putting ice packs in the groin and the axilla and next to the carotids and next to the major arteries, well, how does that one, you know, stack up with the rest? Well, not so good. So the cooling rate is, you know, very low, certainly unacceptable for, you know, anything that we want to do to cool somebody quickly. Again, we have about 30 minutes or so to do this to reduce morbidity and mortality. So Ice packs in the groin and the axilla, not going to cut it. So what else? So we look around the ER. We have a cooling blanket. We have a cooling blanket in the ER or in the OR, something we have access to. This is a vinyl blanket that has channels that run through it. And what you do is you hook it up to this machine, and the machine pumps cold water through this blanket. So you put the blanket on the stretcher, you put the patient on the blanket, and then cold water is pumped through this thing to cool a patient. You can see it even comes with its own rectal thermistor so that you can continuously monitor somebody's temperature. What do we think about this? What do we think about a cooling blanket? Well, barely makes a blip on our graph. So certainly not something that we are going to use to cool somebody emergently. Certainly not going to be effective in cooling somebody with exertional heat stroke. So that's out. What else? How about cold IV fluids? If we keep a couple of bags of saline or something in the refrigerator, then when somebody comes in, we can use cold IV fluids. How's that going to work? Again, not so good. This is an unacceptable way to cool somebody. Certainly doesn't have the cooling power that we would expect or need with somebody with exertional heat stroke. There was a study done in the military that you can do this kind of stuff in the military. They started an IV in the hand or the wrist, and then they had a mechanism to measure temperatures in the shoulder. And they started cold IV fluids in the hand, and guess what? By the time it got to the shoulder, it was body temperature. So cold IV fluids are not going to work, certainly in somebody who's 108 or 109 degrees. So that's out. How about rotating cold towels? Just taking towels and dipping them into ice water and then putting them on the patient and then rotating them out as they start to warm up, continuously cooling people. What about that? Well, that's actually pretty good. That's actually a pretty good method of cooling somebody, and it's certainly encouraged, especially with, if you're the first one on the scene, or, certainly folks in EMS, if you're at an event or you come to an event and there's a cooler of ice water, you can start dipping towels in it and start cooling somebody down. This is an acceptable way to start doing that. So this is good. But I do ask you to think outside the box, right? So we're EMS folks. This is what we do. We invent on the fly. We do things on the fly. We think outside the box. And I mention that because this is what we call the TACO method. So this is the Tarp assisted cooling, or TACO method. And really what you do is you take a tarp and you put the patient in the tarp, and then you add 10 gallons of water, 20 gallons of water, and 10 gallons of ice, and slosh them around in the ice water. And that's a pretty good cooling rate. And it's almost as good as putting somebody in a tub. And again, if we look at the TACO method on the graph, again, this is an acceptable way to do it. So what have we done in the ER? And we've done this twice this year, actually, in our ER, is we take the postmortem shroud, right? It's an impervious vinyl shroud. It looks like sort of like a sleeping bag, if you will. And you open that up, and there you have the burrito, what I like to call the burrito method, right? It's like the TACO method, but it's a lot less messy. And this you can do in the ER. You can, again, put the patient in there, puts a couple gallons of water, a couple gallons of ice, and sloshing around, and you have a pretty effective cooling method. So the TACO method, burrito method, is actually a great method for cold water immersion if you don't have a tub or you can't use a tub. So it's a great way to do it, and certainly an effective and ideal way to cool somebody. And it's been done. This is a case report that was published in 2019. This is somebody who, this is a lady who I believe had a classic heat stroke, but she was, hyperthermic. She came into the ER, and they used the body bag. They used the impervious shroud, again, as the sort of the burrito method to save her. So again, this has been done. We've done it twice this year in the ER at Fatima, both times successful. And it is a rather easy and not so messy way of doing it. But where are we limited? Well, this is our ice machine, and you may have an ice machine that kind of looks like this. It gives you a cup of ice at a time, but we're talking about 10 gallons of ice, 20 gallons of ice. We need a lot of ice, right? So you have to think about that when you're going to cool somebody. You have to either have a mechanism to get yourself lots of ice, or start, somebody getting lots of ice, and or send somebody to the cafeteria to get a big bucket of ice or something like that. So you have to have that mechanism in place. So I bring you back to this and say, again, Heat stroke is a diagnosis that has to be recognized and treated quickly. We have, we're on the clock just as we are with some of the other diagnoses. So they revisited the original article that was published in 2007 and said, not only is it important to treat heat stroke with cold water immersion, but it's important that we treat it before we even think about transporting. So this is where the mantra, the cool first, transport second, comes from. And it essentially means just what it says, cool somebody before you start transporting to the hospital or to definitive care. I'm going to talk about now two different heat strokes. This is a study that was done by a colleague of mine. This was at the Marine Corps Marathon, and these are two runners in the Marine Corps Marathon. The first one is the dark circles, and this is a runner who finished the race, so 26 miles, 26.2 miles, finished the race, collapsed at the finish line. He was immediately met by the medical team, immediately brought to a medical tent. You can see that they got a rectal temperature at time 0, and then cooled him in a cold water immersion tub, and his temperature came down within 30 minutes, and he survived and was discharged. The other guy, the guy with the gray squares over here, what happened to him was he collapsed at mile 24. So somebody called the ambulance responded, the ambulance picked him up at mile 24, brought him to the local ER, and then they started to recognize heat stroke there. You can see the problem, or should see the problem from the get-go, is it took more than an hour to get the rectal temperature. So by the time they picked him up from the scene, by the time he got to the ER, by the time somebody in the ER, thought to take a rectal temperature, and again, I'm an ER doc, I can say that, it took a long time to get a rectal temperature. It took a long time to recognize that he was having exertional heat stroke, and then took a long time to cool him. He stayed in the ICU for a long time. He had both renal and liver failure. He was put on the transplant list for a liver transplant, but fortunately he recovered and did well and did not require a transplant, but had significant time in the hospital and sort of significant injury because of the way he was treated. So again, just shows you the difference between the treatment of two different heat strokes. And this is my favorite heat stroke story. This is Gavin Class. Gavin played for the University of Towson in Maryland. Gavin was practicing for the football season, and he had a heat stroke, and he collapsed from exertional heat stroke. There was an athletic trainer right there who identified it right away. They brought Gavin over to a cold water immersion tub that they had waiting on the sideline. They put him in the tub. And then did what they are supposed to do. They called 911. The ambulance is right across the street. The ambulance gets there within 5 minutes. What did they do? They take him out of the tub. They said, well, he's our patient now. We take him out of the tub. So when he arrived in the ER, by the time they got a rectal temperature there, he was in the realm of 106 degrees. Gavin spent a long time in a coma. He had 21 surgeries, including a liver transplant because of both kidney and liver failure. And he did survive. This is Gavin in 2018. He is now a strength and conditioning coach because he is not allowed to return to, he was not allowed to return to football because of his injury and liver transplant. So again, just the importance of cooling, cooling first and transporting second. So as you guys know, if you're an EMS is certainly protocol driven. We do everything by protocol, and certainly this is where policy comes into play. So I asked you to think about cardiac arrest, change gears a bit and think about cardiac arrest and think about how obviously this is a serious diagnosis, a serious condition, and something that needs to be treated timely, right? So you can imagine back in 2017 or so, when in Rhode Island, we changed the protocol that said that anybody in cardiac arrest was going to be treated on scene for 30 minutes before transporting to the hospital. So when I first heard that, I thought, oh my God, that's the most ridiculous thing I've ever heard. What, these are people that need to get to the hospital right away. But then you look at the science, right? And this was a study done in Japan with, thousands of people. And what they showed was that if you stayed on scene anywhere between 30 and 42 minutes, that the outcome was more favorable. And if you think about it, what do people need with cardiac arrest? They need compressions and maybe an AED, right? So they don't need me to do that. Bystanders can do that. So, stay on scene, give good quality CPR, good quality compressions, maybe an AED if they have the right rhythm. But stay on scene, take care of these people on scene. And it works. This was they showed in North Carolina, there were 3 times more CPR saves in just a 6-month period. So this stuff works. So again, the science is there. This is a diagnosis that you treat on the scene before you even think about starting to move. So the protocol now in Rhode Island anyway says that regardless of how close you are, you stay on scene for 30 minutes minimum. And again, give good quality CPR and AED or electricity if you need it, and stay and take care of these people before you even think about transporting. So you think about it. Can we do this with heat stroke? Well, we can, and we did. This is Connecticut. Congratulations to our Connecticut folks. This is the first protocol of its kind that says you're going to cool first and transport second. Not only that, it allows for EMS folks to take rectal temperatures. So they are going to assess a rectal temperature for core body temperature. And if somebody's hyperthermic, if they're above 104, and they're going to start cooling on scene and cool first and transport second. It also allows that if you find somebody in a situation where they're cooling, like Gavin, you're going to stay and cool until they're down to 102 before you start to transport. So again, this is the first of its kind. This was written by a friend of mine in Connecticut, and we shared the protocol, and certainly this is again, I think where we need to be headed with EMS. This is Maryland. Maryland sort of followed suit. The end of last year, they put out a protocol that did say that if you come upon a scene where somebody's actively being cooled, that you're going to wait until their body temperature comes down to 102 before you attempt to transport. Again, this is thinking about Gavin. He would have certainly benefited from staying in that tub as opposed to being rapidly transported. So again, this is the cool first, transport second idea. If you look at other protocols, Massachusetts, forget it. Massachusetts protocol, and again, I live in Massachusetts. This protocol is a mess. If you think about, Massachusetts, the home to the Boston Marathon, the home to the Falmouth Road Race, and they're putting cold packs in the armpits, neck, and groin. So again, there's some work to be done, certainly with EMS. Rhode Island, not so bad. It does define heat stroke and cooling and stuff like that. A lot of these things perhaps not specific enough. So it leads me to this consensus statement that we published in I think 2018. Now it was in Prehospital Emergency Care. What we did was we gathered a bunch of emergency medicine docs and sat around a table and kind of hashed this all out and said, how can we best get this message to EMS? How can we best take care of exertional heat stroke in the pre-hospital setting? And really, what we did was come up with this basic paradigm, and 4 things really: rapid recognition, rapid assessment, rapid cooling, and rapid advanced care. And that is the sort of the paradigm for EMS as seen in this article. So I'll use this as a form of summary, if you will. So again, rapid recognition: recognize exertional heat stroke, the signs and symptoms of exertional heat stroke. Again, the definition of a temperature greater than 104 with altered mental status. So that's the definition of exertional heat stroke. Rapid assessment: I think I hopefully I talked enough about the importance of a rectal temperature to measure core body temperature. I know it's there's a stigma against rectal temperatures, and it's tough, but it can be done. It can be done privately, and certainly can be done efficiently. Cold water immersion, again, cold water immersion as the gold standard for cooling, clearly superior with a cooling rate. I think we showed that. And then again, make sure you use something that has a significant cooling rate. Again, if you don't have a cold water immersion tub, the Tarp method, the taco method, the body bag method, the burrito method, any of those methods are acceptable for cooling. Again, rotating cold water towels is a great way to start, but certainly you need a method that's effective for cooling. And then rapid advanced care, remembering to cool first and transport second. And again, Connecticut with the first protocol of its kind that outlines that for EMS. Cool first, transport second. Cooling on scene is important before transporting. So back to our EMS conundrum, again, scoop and run, stay and play. I hope that I've kind of showed you that stay and play is certainly where we want to be with exertional heat stroke. I think it's important to certainly cool somebody first before we transport. It's again, 100% survivable if somebody is cooled within the 30 minutes or so. And, we've shown that with, nearly 400 people. I do want to show you some, pictures I found that, again, we're EMS folks. We do things on the fly. We're very innovative. This is in Austin, Texas. They used a shopping cart with a tarp and then filled it with ice water. So again, if you don't have a tub, you improvise. And they used this method to cool a person who had heat stroke. So again, kudos to them for thinking outside the box with the tarp method. And they also, had their, this again is in Austin, Texas. This is a mini taco method, if you will. This is one of those people movers. You can see that it really doesn't wrap all the way around somebody, but they used it to, fill with ice and water, and they, started cooling somebody on scene and probably even during transport. So again, can it be done? Sure. But I think it's, again, the whole message is to cool somebody before even transporting. Because we can't do this in there, right? We can't really do that effectively in the ER. So again, so the message, hopefully the message, cool first, transport second. You see how important it is to cool somebody quickly. You have a, limited time span. You've seen some examples with, Gavin Class and the two runners at the marathon, how important it is to cool quickly and before you transport. This is the KSI website, ksi.uconn.edu. And if you go to the website, you can see there's lots of drop downs. There's lots of information. We did this educational video with the NFL. We filmed it at Gillette Stadium. We did it for the NFL, and it was rolled out to all 32 NFL teams. So again, if you want to look at that video, it's a reenactment or an example of what it actually looks like to put somebody in a cold water immersion tub. And then finally, of course, we are on social media. If you want to follow KSI on social media, you can look into what's going on. And again, on behalf of my team at the Falmouth Road Race, I certainly thank you for paying attention to the lecture. Thank you for joining on. This is my email. You can get in touch with me if you have any questions, concerns, you think of anything afterwards. Certainly you can use that. If you're interested in joining us at the Falmouth Road Race, it's August 15th this year. You can either email me or you can go online and register as a volunteer. We'd love to have people and have them see what actually happens and how it is to use cold water immersion. So that is it for me. There's probably some, I don't know if there's any questions here in the chat. I'm going to take a quick look. I don't see any questions. So if anybody, if you have any questions, you can either unmute yourself and certainly ask, or you can put it in the chat box and I'll take a look. You can email me, whichever works best for you. For the folks that in Rhode Island, or my, people who come to rounds often, or again, if you're interested in rounds coming up, we are going to take the month of August off unless there's a pressing issue that comes up that we have to address with the rounds. We'll probably take the month of August off. Again, August is the month for the Falmouth Road Race, so I'm going to be, busy with that and doing stuff with that if you wanted to, again, be a part of that. And then we will return with rounds in September. September 8th is the second Wednesday in September, and that's when we're going to have our lawyer join us. We have a lawyer to join us and talk about legal aspects of EMS and documentation and things like that. She's done rounds for us before, and it's been a great presentation, and so she's going to be doing that again with us. I thought initially that we may be live by September, but I have to say, after seeing almost 100 people tonight virtually, that may be the way to go. So we'll see about that. But certainly we'll advertise for the next rounds will be in September. So again, let me just check for any questions in chat, and otherwise. There is a question for any suggestions on thermometers for EMS. If you want to invest in a thermistor, that's a possibility. Otherwise, I think that you just get a disposable thermometer from like CVS or Walgreens or something like that, and just carry around that's what they use at the Marine Corps Marathon. They use the little one you can buy over the counter at CVS, one-time use kind of thing. And, the thing about it is you'll have to, continually take temperatures to see where you're at as far as cooling. But again, it's a cheap device that you can get. If you do have some, funds, a thermistor is nice so that you have, continuous monitoring. Can those of us on this Connecticut list get notified of that? Would that be this, you talk about the next rounds? We can certainly send out an invite for that. Should a barrier be placed between the patient and the ice? No, we don't. Again, you're talking about somebody who's 108, 109 degrees when they go into the ice water. The ice starts to melt. You want to cover as much body surface area as you can. So, and again, that thin layer of water right next to the body actually starts to heat up. So you want to keep the water circulating. You want to cover as much body surface area. And if you do the calculation, again, if you look at the cooling rate and how hot somebody is and how far they have to cool, it's usually about 20 minutes. So there's really not a lot of exposure to ice or concern for, hypothermia or, frostbite or something like that. Okay, another question. Apologies if this is too in-depth, but if EMS cannot access ice, what are the recommendations? Well, that is the problem, right? And again, being in the EMS world, I understand that you can't be carrying around ice tubs. I understand that you can't be carrying around coolers of ice, unless, maybe, and I've talked to some EMS people about this, say there's a heat wave, say, the weather service is predicting over the next 5 days, there's going to be a heat wave of, ungodly temperatures and humidity. Maybe you can carry a cooler of ice in the ambulance while you're out for the day. Again, rotating cold water towels, just dipping the towels in cold ice water and then rotating them is certainly an acceptable way. And anything to start cooling is better than nothing. So I think that, that's certainly a possibility. Let's see, get the fire department to bring ice from their station, send someone to in a restaurant or a gas station or nearby the scene. And yeah, that's great advice, right? Get ice wherever you can get it. Again, if you're in the ER, we typically have to send somebody to the cafeteria because we just don't have that much ice. If you're out, again, if it's an athletic event, if they have a cooler with ice water, then you're all set. If you have to, again, this recommendation is great. Go to a restaurant, go to a gas station, ask for ice. And that's a great idea. Another question, do you keep putting patients in a tub one after another, or do you have to add a lot of ice before the next patient? You do have to add ice. Like I said, when you put people that are that hot into a tub, they do melt the ice, and we do, as you may have seen in that picture, we do have lots of tubs. We have lots of ice tubs ready to go, and we will reuse them if we have to, unless they're soiled, unless there's body fluids or something happens that we can't use the tub, we'll sort of put it out of service, if you will. But if we have to reuse tubs, we we do our best to kind of keep it as clean as we can, but we do have to, refresh the ice, so to speak. So any other questions? Again, my email is there if you want to email me, if you think of something after, or if you think about volunteering at the race, you want to join the race, you have an event coming up that you need help with, we can certainly do that as well. 2 questions at about the same time: is pond water or lake water sufficient for cooling? If that's all you have, and somebody asked about a pond, river, ocean, etc. Sure. I mean, if you can get cold water from wherever you can get it, you can get ice from wherever you can get it. I think either one obviously is acceptable. Again, anything you can do to start cooling is going to be better than nothing. Rotating cold towers is great. Any other questions or thoughts, concerns? I'll stay on for a little bit if anybody wants. Otherwise, that really concludes the program. I can't say thank you enough. We had about 120 people sign up. There looked like there was close to 100 on. So that's great participation. I really appreciate it. And like I said, feel free to reach out to me. You guys in Connecticut, KSI is at UConn. Feel free to reach out there as well. And for those of you who have people who are interested, or you have, or again, if you're interested to hear it again, this was recorded. We'll make that link available to everyone. The other thing is, I am doing this again for Connecticut, for Hartford Healthcare on July 29th. So again, folks in Connecticut, if you have friends or colleagues that want to see this, I will be doing it again in about a week or so. And again, it's recorded if you need it. Do we get a certificate? Yes, you'll get a certificate of participation. You'll get certificates from Eileen. Will email a certificate. For those of you in Connecticut, I've spoken with Dr. McLean. My friend Kyle McLean is going to take care of Connecticut certificates so that you get the proper credit for continuing it in Connecticut. So that'll be done as well. Someone just commented on chat, if the fire department are present on scene for a heat emergency call, could they use the dump tank with water from the engine or tanker to be acceptable in ice? Absolutely. The dump tanks are pretty big. You'd have to, be careful not to, have the water be too deep that you can't control the patient or get under the water or whatever, or get in there with them, I guess. But yeah, absolutely. Any container, as you saw, I mean, any container, a tarp, a body bag, a grocery cart with a tarp in it, anything that'll hold water and ice is sufficient to do it. What's the best position to take a rectal temperature to lie them on their side? That's typically what we do. We'll have somebody lying on, turn somebody on their side. Again, at the race, typically they're wearing shorts or, some kind of running shorts and it's very easy to either, kind of go up through the leg of the shorts or just pull the shorts down. We cover patients with a sheet or a towel, and it's done discreetly, it's done easily. And again, most times patients don't even know it's being done. They're somewhat altered. And don't know the thermometer is being inserted. There are people who, their change in mental status is that of combativeness. There have been patients that have been combative, and sometimes it takes just a little bit of muscle to kind of help with that. But again, Yeah, the temperature can be done very discreetly, with the patient covered, and you get a good, obviously you get a most accurate core body temperature. Do you attempt to take blood pressures in the tub? Absolutely, yeah. Like as I showed you with the 50-gallon tub, typically the arms and legs are, can be out of the tub, and it's certainly quite easy to take a blood pressure with the patient's arm out of the tub. To be entirely honest, when somebody comes into the tent, and again, I've seen a lot of exertional heat stroke. If we know somebody has exertional heat stroke and we get a temperature, and certainly that proves that they have exertional heat stroke, we'll get them right into the tub before we start doing blood pressure, pulses, and things like that. We kind of wait till they're at a better place before we start taking blood pressure, pulse, etc. Because we know the most important thing is cooling. I think the only thing that would preempt cooling would be obviously a cardiac arrest when you have to, use an AED or something. But certainly any other case, the first thing you want to do is get somebody in the tub. How frequently should a temperature be taken if not able to continuously monitor one? We typically say every 5 minutes, knowing though that the first 10, 15, 20 minutes, there's not going to be a heck of a lot of movement with the temperature. Like I said, sometimes you may even see the temperature go up a little bit. So, you get the person in the tub, and then as they start to cool, it may be, 10, 15 minutes later, then you can start retaking temperatures, to see where you're at. And then probably every 5 minutes after that. Again, you want to stop cooling when they're about 102. You don't want them to go too cold. You don't want them to overshoot and get real cold. So that's the importance of, monitoring their temperature. And then you want to monitor afterwards too, while they're recovering, while you're watching them to recover, because again, very occasionally somebody may shoot back up and have to get back into the tub. That's happened a few times. All right, there's another question. Have you seen someone get below 102, like 100, then they keep dropping when they are out? What would you do? Well, what we do is actually start to rewarm people. Again, our event is in August. We have the benefit of sunshine. So if we get somebody who sort of overshoots and then they start to get cold, again, we've seen people go down to, say, 95 degrees. We just put them out in the sun. We have an area of the tent that is walled off but has no roof, and we have people that'll watch. We can recover people outside. By then, their mental status is improved. They're awake. They're alert. They're taking PO, but they just may feel a little chilly. So we put them out in the sun again, and let them sort of warm naturally. Again, we think it's the hypothalamus as the thermostat that doesn't really reset right away. So some people do take a while to heat back up, but or feel better, I should say, after being cooled. But it's never become an issue. It's never become a problem. I should say too that the people, like I said, about 90% of the people go home from the tent. The people that have gone to the ER, no one has ever been admitted because they've all sort of recovered in the ER and been discharged. Okay, so it's 7:30. If no one has any other questions, I'm going to sign off myself. Again, I thank you all for being a part of this. I thank you all for joining. Again, my email, feel free to use that. You can contact me that way. You can contact me through KSI. This has been recorded, so it's available. Again, we can send out the link. You will get certificates either from Rhode Island or Connecticut if applicable. And again, I'll be doing this again on the 29th if anybody wants to rejoin or revisit or has somebody who would be interested. So again, thank you so much, and thanks for joining. Eileen, I think we can stop recording and we will